Okay, welcome to Thinking Green. I'm Rana, and today's show is really a matter of maybe a little more urgency than a lot of the shows. I know we have frequently talked about healthcare access and the need for a universal single payer system, but it seems like we've been forced into being a little reactive and not just proactive with some recent developments. So I'm happy to introduce my guests, Dr. Claire Cohen, who is a pediatric psychiatrist in the Pittsburgh area and works on health policy for Democratic Socialists of America. Sivan Amar, who is one of our founders of Medicare for All Connecticut and is also involved with DSA, and Marilyn Vacher, who is a practicing psychiatrist who lives in New London, who was one of the founders of the Connecticut chapter for Physicians for a National Healthcare Program, PNHP. So welcome, ladies. And today's topic is direct contracting entities, which I'm guessing most people have never heard of. It's a little bit like Medicare Advantage plans, but goes a step farther and is a bit more of a threat. And today we're coming together to explain what they are and what the problem is and what we can do about them. So welcome all of you. And I guess, I don't know if you want to each talk a little about why you're involved in this whole fight before we start talking specifically about DCEs, but I'd love to have you say a little bit about yourselves and start anywhere.
I can lead off because I'm an old person, which means I'm on traditional Medicare. And in addition to my professional concerns about this, as an individual, I have come to learn that I may be removed from traditional Medicare and put in a managed care organization without my knowledge or consent as a result of DCEs.
Okay. I'm a physician who has for a long time believed in and been supportive of single payer health care. But I just turned 65 last year, haven't quite retired, but I've already signed up for Medicare Part A, which you can do, you have to do at 65. And I was intending when I retire in a couple of years to sign up for Medicare Part B, traditional Medicare, when I learned about this program. So just like Marilyn, I have not only a activist interest in this, but I have a personal interest. And I have to tell you, I might be smiling because I'm right now on the show, but I am very angry. I feel betrayed that I come here expecting to sign up for traditional Medicare and I'm finding this mess instead.
Sivan.
So I'm not on Medicare, but I pay my taxes and every paycheck I pay towards Medicare, and seeing the direction that the DCEs, the direct contracting entities, want to move Medicare also angers me, because they're trying to do it through a sort of Trojan horse model, as Marilyn and Claire were saying, without people's understanding, without their own permission, without Congress acting on it or speaking to it. So again, though I'm not on Medicare right now, I hopefully will one day turn 65 and be able to access that plan. And I hope that it'll still be there, because it's one of America's most favorite and popular programs. I've lived overseas and had access to universal single health care as a patient, and thought it was fantastic. And so I, like Claire, am angered by the misinformation and disinformation that is peddled by the lobbying industry here, that says that universal healthcare can't be achieved in this country. And when they're trying to sabotage even our current form of Medicare through these DCE programs and other capitation programs, it's very scary.
And I want to add that I'm also an old person. I'm on Medicare. And my husband worked for the state of Connecticut for over a decade. So we get our insurance through the state of Connecticut retirement pool. And when we signed up, probably about 5 years ago, we signed up for Medicare A and B, and the state was the supplemental insurance, and it was really great coverage. About 2 or 3 years ago, United Healthcare made a really good pitch, I guess, to the state of Connecticut, and everyone in the retiree pool was forcibly transferred to an Advantage plan. We didn't do it. We were informed of what was happening, but it was a decision made by the state comptroller. And I'm guessing, I really think the United Healthcare must have considered it a loss leader and given this particular pool a very good deal just to get a foot in the door and to have more clout. And I won't say there has been a change in my coverage, but what has been a change is in an attitude. Every week we get some kind of mailing from the insurance company. You're not taking advantage of our gym membership, and go get this test and go get that test. And aren't we doing a great job, and fill out this survey? But about a year ago, my husband fell in a park on the ice, and he broke his femur and had to have a hip replacement. And it was all covered. But before the insurance paid it, they sent him a letter saying, where did you break your hip? We might be able to bill, at the store or office building where he fell, so that their insurance will pay for it. And they only gave two choices, something like in an office, in a retail establishment, or at home. And we figured, the city parks are our backyard, right? So he said at home, and they paid it. But the fact that this was a health need he had, and they were trying to wiggle out of paying for it by making someone else liable for the accident, is just something that never would happen under a traditional Medicare program. So to see other people, being transferred in some states against their will to an Advantage plan, which isn't what they want, it's something I kind of experienced, and it's not good. So I guess at this point, we should really explain what a direct contracting entity is. So I don't know, maybe Claire, you want to start out with that?
Sure. So a direct contracting entity is something that was actually cooked up in the Trump administration. They're for-profit entities which have been given permission by CMS. CMS is the Center for Medicare and Medicaid Services, to act as middlemen to manage the care of people on Medicare. In other words, it's a step further than it's what Medicare Advantage does. They're insurance companies that have been given permission to manage your care, do the managed care. But in this case, it doesn't have to be an insurance company. It can be a private equity firm. In fact, most of the ones signing up for this are, or venture capitalists, and they would have permission to manage your medical care. And they would not go to you to get permission the most current program, there were two different programs, but the most current one, the one that Biden is continuing, is one where they get PCPs to sign up to be under these investment firms. And the PCPs, just because your PCP has signed up, it's called alignment, you will automatically be put into it. You don't have any say.
PCPs being primary care provider.
Your primary care provider. Okay. Sorry, okay. So primary care provider. You need a little bit of information. I'll give you this information. It's not a lot, but it'll help you see the picture. Traditional Medicare is so efficient that 98 cents of every dollar, that tax dollars you put in on your taxes, that goes to the Medicare Trust Fund, 98 cents of every dollar goes to direct patient care. Now, when they made a contract with these Medicare Advantage insurance companies, they required them to put at least 85 cents of every dollar to direct patient care. Because, of course, these companies wanted to make profit. And they said, that's okay, you can make profit. But so right there, they're less cost efficient, no matter what they say. So they said, but you have to put at least 85 cents of every dollar into direct patient care. The DCEs have been told you have to put 60 cents of every dollar into direct patient care. So every dollar you're putting in, only 60 cents is going to your care. 40 cents is going to someone's profit and administrative costs, which we know that administrative costs aren't quite that much. So in other words, they have their hand in the cookie jar and they're leeching off your money, the public's money, to make profit. So they're called direct contracting because CMS contracts directly with them. It's not with you to manage your care, and they give them a certain amount of money. The way this works, both for MA and is working for DCEs, for direct contractors, is traditional Medicare. The doctor does a service, he bills Medicare, Medicare pays him. With Medicare Advantage and DCEs, the way it works is there's a concept called capitation. In other words, the Medicare Trust Fund, CMS, gives them a certain amount of money they give it monthly for each person they have enrolled. But it's not the same amount for every person. They have something called risk scoring. And risk scoring means for sicker people, you get a bigger amount of money. So for example, if you were 95 years old, had not a medical problem at all, was completely healthy, and these are figures that are a couple years old, you would get $4,000 for the year for that senior, divided into 12 monthly payments. But if you start adding risk scoring for conditions, you start getting more money. So for your average, somewhat healthy senior, maybe controlled hypertension, controlled asthma, pre-diabetic, you would get, let's say, $9,000 for the year. But for somebody who's supposedly very ill, you would get $32,000 for the year. Okay, so you get this, and what your job is to find out how to make a profit out of that. As long as, if you were Medicare Advantage, you don't spend more than 15% on profit. In the case of DCEs, more than 40% on profits. That's called medical loss ratio. Okay, so one of the ways that the Medicare Advantage companies have really gamed the system is they've become masters of fraudulently coding. Okay, so they have all these people that aren't that sick that and I'll give you and you have a slide that shows, but I don't know how to tell you which slide. So I have hypertension, it's controlled. So how they would upcode on me is they would say I have malignant hypertension, that upcodes. I do have asthma, it's controlled. They would say I have COPD because technically asthma is a form of COPD. Okay, COPD is obstructive lung, chronic obstructive lung disorder. So asthma is an obstructive lung. So technically, but usually doctors, when they say you have COPD, they're referring to something like emphysema or something more severe than asthma. But they would put COPD. I'm using myself because I'm a perfect example of how they could upcode. I am pre-diabetic. Okay. I'm right on the border. They would put me as diabetic with retinopathy. I don't have any retinopathy, but I get checked every year for that. Okay. So they would, by the time they got through, I am obese. I don't look it, but I am obese. They would put me as morbidly obese. So by the time they got through, I could look very sick. So instead of getting $9,000 a year in capitation for me, if my doctor was contracted with this direct contracting entity, CMS would be giving $32,000 a year for me. In between 2018 and 2019, the CMS was defrauded of $34 billion through this upcoding. Okay. Other ways they make money is cherry picking, which means they only try to sign up healthy seniors or relatively healthy seniors like myself, relatively healthy. And when people get very ill, because I know a lot of people who are signed up for Medicare Advantage and they like it because they give them gym, as you said, they give them all these things. But if you get very ill, you have a stroke, you have a massive heart attack, you have renal failure, or you have a really bad cancer, then they want to dump you off on traditional Medicare. That's called lemon dropping. And that problem has been so bad that the Inspector General of the United States has gotten involved. And they won't relist the names, but they cited 20 Medicare Advantage companies for doing this kind of dumping of very ill people, some of whom we understand actually died as a result of this dumping thing. So, and they also we try to restrict care once you get very ill. So they make this is how they make money, by doing all these things, by upcoding, by restricting care, by denying care, by making you pay, just like under ACA insurance companies, the surprise billing, by cherry picking and lemon dropping. They do all these things.
Well, when you were talking about upcoding, I was wondering, what I had observed since I was moved to an Advantage plan is that many of the mailings that we get they want me to, they want us to get all kinds of tests. They want to make sure, even without symptoms, get your eyes checked, get this checked, get that checked. And I do wonder if now, listening to you, if that's a way to get some sort of basis. Oh, you're pre-diabetic, or you had a cyst when you had a mammogram, or you did, they find some small something and they can turn that into a real risk that they can turn into profit.
You're exactly correct. That's what happens. So so this whole concept. Now, a lot of what I'm telling you, the reason why I keep mentioning Medicare Advantage is because DCEs are so new that we don't have the data to substantiate our concerns, because they just started last year. But MA, the Medicare Advantage, has been around for over 20 years. 20 years as Medicare Advantage. It was called Medicare Choice before that. And so there's a lot of data that, and they are certainly doing these things, doing everything we're saying. And and when you look at the industry and why they want to get in private equity, why they want to get into the act, it's because Medicare Advantage has made a killing. In fact, they're depleting the Medicare Trust Fund at an alarming rate. They are making a killing doing this stuff. And the rest of Wall Street is looking and saying, we want to get on some of that too. You only have 23 million seniors. There's another 38 million who are on traditional Medicare. If we could get that money, we could make a killing. Yes, we would deplete the system and eventually bankrupt it. Who cares? We'll have our profit. We'll walk away. and leave the whole system a shambles.
Yeah.
So we don't think that they're coming into it because they want to take care of people's care.
Now, one question, whenever we hear the hype about the Advantage programs, we're hearing this on the Connecticut Roadmap program for primary care providers as well. They always promote that their goal is to provide care while streamlining the system or saving money or being more efficient. And
Okay.
and yeah, you mentioned that traditional Medicare, only 2 or 3 cents to the dollar go to administration. So where are savings coming from?
Okay, so this is a wonderful question. Wonderful. Okay, and I'm going to use some of Medicaid and Medicare to make my points. So first of all, I'm going to say something about Medicaid. Right now, Medicaid is practically virtually privatized. A lot of Americans don't realize that. There are only a couple of states that have. Are you talking?
Oh, yeah, Connecticut is one of the 2 states where it is not privatized.
Privatized. That's what I
So
was
we're
gonna say.
naive.
Yes. So Connecticut and Kentucky are the only 2 states that still have public Medicare. So the Commonwealth Trust Fund looked at studies because the whole thing that the industry was presenting is we can provide better quality care at lower cost. That was the whole way they convinced all these states to go in to privatize their Medicaid. So this has been going on for enough time now, because it's been going on for 5, 6, maybe even 7 years. That people are looking at studies to see the impact. And the impact is, guess where the most cost-effective, highest quality Medicaid services are? Connecticut and Kentucky. And studies have shown, every study, I think every study has shown, I read the Commonwealth study a little while ago, that by privatizing, you have decreased quality and increased cost. Okay. Now, the Commonwealth Fund's conclusion from this is, well, we have to figure out how to balance this more. So balance this, but their conclusion should have been, we need to go back to public Medicaid because it is the most cost effective and provides the highest quality. Now, to go to Medicare, when the ACA was written up, there was a little known provision in it that created a department under CMS, under the Center for Medicare and Medicaid Services, called CMMI, the Center for Medicare and Medicaid Innovation. And we just call it the Innovation Center for short. And supposedly the mission of this innovation system was to develop models without needing to get permission from Congress. This is how DCEs came about, to develop models to increase the efficiency of Medicare, increase the cost effectiveness without decreasing quality, or to increase quality without increasing cost. Okay, that was the mission, and they would not have to get permission from Congress like these departments usually have to. They could just run it on their own. And this is so the head of CMMI, who was picked. This head of CMMI, Liz Fowler, she comes out of an insurance industry background. Well, in her mind, this is the way to do it. Okay, privatizing. Okay, so even though we are clear now that privatizing, that's been done so far, and it's been done so far under Medicare Advantage, has not been more cost efficient, has not provided higher quality care. Just the opposite. She is so blinded by her neoliberal ideology, her belief that if you meet the interest, of the greedy, it will take care of the needy. That's what neoliberalism is. I do what the greedy want, that'll take care of the needy. Okay, for those of you who don't know what neoliberalism is, she's so blinded by the ideology that she can't see the facts in front of her face that show that this is less efficient, less cost efficient, and providing less quality. So she's putting, so basically DCE, the direct contractor program, is Medicare Advantage on steroids. So she's going in the exact opposite direction to give more profit, more privatization, and we can be sure there'll be less quality and less cost effectiveness.
Now, I have a question for Marilyn. Since you are in Connecticut and you practice in California, how are you affected by like Medicare and Medicaid? Do you have to do California style billing or Connecticut style billing?
Yeah, as an employee for an agency in California, I don't have to do any of the billing, but I do have to operate within their managed care framework for their Medi-Cal patients, which is what they call Medicaid. It's the same as Husky here. And so just this week, I had to spend a fair amount of time online and on the phone getting approval for medications that I know are covered by Medi-Cal. But because it's a managed care program, I still have to do prior authorizations. And just multiply that by thousands and thousands of patients and practitioners all around the country. That's how Medicaid is working for them, and that's how Medicare Advantage programs are working or not working for both the patients and the practitioners.
Yeah, I think I've heard at times there is a crisis and like not enough physicians around in the United States. And it seems as though the industry answer to it is to incentivize them to make more money by the upcoding and the other sorts of things. But I know that physicians I've often talked to are just burned out by the administrative load of their jobs, which they felt wasn't really what they signed up for when they went to med school. Do you two, physicians feel that way?
Yeah. Go ahead.
I can speak to the cost for a private practitioner. There's all the work that I kind of alluded to, but also to do all the billing and prior authorizations and interacting with insurance and interacting with the pharmacies and the pharmaceutical companies. Many practices, and you've probably observed this if you've gone to your doctor's office, have a whole regiment of people in the back office doing nothing but administrative work, which is one of the reasons many physicians are on board for a single payer healthcare system. We don't want to have to manage all those people, much less pay them.
In my activism as well, speaking with the general public, I once met a person who's a medical biller in a medical office, and her job is solely doing that admin work. And she said that she herself is burned out and sees the sort of ridiculousness of all of the either upcoding or having to do so much additional work because every patient is on a different insurance plan or a different form of Medicare or Medicaid, that even the people who do the administrative work are burnt out from this as well. So it's a real problem, and it's really, as we were saying, what amounts to so much of the waste and so much of the additional cost that comes out of that cents per dollar. When Claire was saying that in traditional Medicare, 98 cents to every dollar, so that's 98% of funds goes towards healthcare. Whereas in other forms, and particularly in DCEs, it's 60 cents or 60% only goes towards care, and that 40 cents goes towards everything else, including profit. Now, if I am a patient on the slab, I would want top dollar being spent to save me, and that's just not what's happening here. So it's really problematic, and what is showing to be the case, and what's becoming increasingly popular among most of the American population, is that we have to move away from a for-profit system. That's for how many years now has our medical system been privatized or been under attack for privatization? These insurance companies continue to not provide services that they advertise for. And that's why we're here. If they provided services, they gave access to care, if they didn't fight tooth and nail, denying coverage, denying everything you go in for, we wouldn't be here. We wouldn't need to complain. We wouldn't need to act against it. But these companies have shown their priorities, and it's not their customers, but it's their profits. And it proves fatal every single time. Additionally, under the DCEs, I read in an article that was published in The Intercept that nursing home facilities that are managed by DCEs have a 10% higher death rate. That is disturbing. That is incredibly disturbing to know that any of us, or my grandmother was just in a nursing facility a couple of years ago before she passed away, could be that 10%. That's not a single digit, that's a double digit. And those are people, those are human beings. So this is incredibly scary.
Yeah, I want to add, first of all, I agree with everything that Marilyn and Sivan have said, because that is the problem. And there actually are studies showing that American doctors spend more time doing administrative work than any other doctors all over the world. And they're the most dissatisfied about that. And it's strictly because they're having to fight insurance companies. And I'll just add a quick little story. I just recently had a patient. I have a lot of autistic patients, and he had been stable for many years on his medicine. Over the holidays, he's deteriorated for the first time in several years. Mother called me and I said, well, let's just up his medicine just a little bit. I know him well, so I had a sense of how far to up it, and that'll keep him stable, so he doesn't end up in the hospital over the holidays. So I sent in the prescription. The insurance company denied it.
And of course, they have no medical background.
No.
They're not doctors. They're business people.
So I was determined to get to their insurance company pharmacy. I couldn't get to them by doing the options they said in the phone calls, because I kept saying due to the holidays, there's an increased call volume. So finally I did a trick that someone taught me, which does work, by the way. I just started start, pushing all the buttons, and then sure enough, I got through. So when I talked to the pharmacist and I explained the situation, but you have to imagine all of this took between an hour and 2 hours to do when I'm supposed to be on my holiday too. And finally I talked. Well, first they tried to tell me that his medicine had not been on. They gave me a whole bunch of crap, but I persisted and finally got him approved. And luckily, as a result, he didn't end up in the hospital. But this was crazy. And the mother was very grateful to me. She said, because Dr. Cohen, this is why I keep you, Dr. Cohen, because a lot of doctors wouldn't fight. They would just give up, but you just kept fighting. And that leads to the second point I want to come to about physician burnout. And I call it moral injury. So when you have to make decisions, or when you're forced to make decisions that harm patients, or in order to not harm patients, you have to go through extraordinary means, like I'm famous for doing, you get burned out. You didn't go into medicine to fight with people who are leeches, whose only concern is how much green bucks they can get, who have no concern about people's health care. At least I didn't. Okay. You went into medicine because at least I did. You wanted to help people, and you wanted to help them get better and have high quality lives. So when you have to go through these fights, and I don't win every fight. I've gotten them, and I've had these insurance company docs, when they call me now, they said, one of them said to me, well, Dr. Cohen, you're known as being very passionate. But it takes a toll on me when I have to do these fights, and it takes a toll on the doctors who don't give these fights. It's a moral injury. And I believe that part of the Burnout for doctors is not only the administrative work, but the moral injuries that's being done to at least some doctors. I'm not going to say every doctors, but to doctors like Marilyn and I, every time we see the distortion of care for our patients as a result of the privatization of medicine.
And there was a time, I have a friend who's an attorney, but she had worked decades ago to representing physicians in Arizona, I think. And she was practicing when the HMO Act of 1973 was passed, and said that, prior to that act, physicians could only work for other physicians because they never wanted any other motive to conflict with the Hippocratic Oath. And that seemed like, the first small step to allow the practice of medicine to become a profit point for some entities. And it seems like everything's been like downhill, and a fight since then.
You're correct. You're correct. That whole under Nixon, when they started the managed care. But by the way, it's not just Republicans. I could talk about Clinton too, and I could even
Absolutely.
Neoliberals, you were saying, neoliberals.
Yes, but I wanted to add something to what you said about that. So the whole premise of these for-profit insurance companies and now investor capitalists, they're saying is that, so first of all, that the United States has the highest costing medical system in the world, but one of the least efficient. Of the 30 to 35, depending who you look at, OECD countries, well-to-do countries, we and one other country, I think it's Slovenia or something, are the only ones that don't have a public good healthcare system, either single payer or a national healthcare system. And we have the worst statistics in terms of death, lifespan, mortality, infant and maternal, and I could go on and on. We have the worst statistics for health, but we have the most expensive system, the United States. It takes 18 to 19% of our GDP, our healthcare, whereas in most other country of the OECD countries, it's like 9 to 10%. Okay, and some as low as 6 or 7%. And so the for-profit entities have convinced our neoliberal politicians that the reason our system is so costly is because Americans use too much health care, number one, and doctors provide too many services. And that's the whole idea behind managed care, to stop these Americans from sitting in the doctor's offices all the time and to stop doctors from providing all these unnecessary services. And they continue to say that, and politicians continue to believe that, despite countless studies over the decades that have shown that Americans use less healthcare than other countries, than other OECD countries. We use less healthcare, and people have more problems getting healthcare that they need, have more problems with access. But you'll still hear these arguments. And indeed, that's the argument behind CMSS's wanting to privatize Medicare. So the issue, and I'll just stop there, but you can see they have this faulty argument that has been proven wrong, and they continue to use that argument.
Yeah.
So, yeah, Marilyn, so you started a chapter of PNHP in Connecticut. Maybe you can talk a little bit about what our healthcare system could look like, and then maybe we can give people some action items for both the short run and the long run.
I'd be happy to do that. I'd also like to say just one more thing about why these DCEs are so dangerous for the overall system, which is all of a sudden 38 million people who are now not under managed care will be under managed care. And it just continues to normalize and make more and more mainstream this idea of for-profit healthcare. Whereas PNHP, Physicians for a National Health Program, and those of us in the Connecticut chapter and Claire in the Pennsylvania chapter are so determined to have public health care. Claire made everything obvious. You know, our costs are higher than other developed countries. Our quality is worse. And that totally reflects the fact that there's a profit motive. Not every dollar that can be spent on healthcare is going to healthcare. And until we have single payer healthcare, it's just going to get worse and worse. And these DCEs are a great example. I'd like to say just a bit more about the DCEs as they exist now. These are, quote, pilot programs, unquote, and they are slated to become permanent and widespread at the end of this year. They are being operated in, I believe, 38 states. There are 53 DCEs ongoing. And in Connecticut, there are 2 DCEs contracted here, but actually no providers signed up. So we're still the lucky ones who have not been dumped into managed care. So it's so vital that we stop this now, and our Congress people can't stop it directly. They have no control. It's totally about us talking to the administration. To get back to your question about what would a public health system look like, just look at the VA. Just look at the Indian Health Service. They have dollars that are spent extremely efficiently and have extremely high outcomes on just every health measure you can imagine. There's no profit. It's all about taking care of patients with the dollars that are provided. We'd like to see those dollars be greater, and we would like to see traditional Medicare include some things that Medicare Advantage plans provide, like dental care and vision care, hearing aids. Those things are not covered under traditional Medicare except with supplements, which are more money to private insurance companies. And so this is another reason why we need universal health care, because under universal health care, we can provide all those things without taking a chunk for somebody on Wall Street.
So what can people do? You mentioned that our Congress people can't directly change this, except maybe in the long run, they could change that little clause in the Affordable Care Act that allows for the Center for Innovation. But what can we do? Are there things in place to make our will known and to get through to our representatives to put pressure on?
Sivan's a big activist. Maybe you can take this one.
I actually have a list of everything that everyone can do here.
Okay.
So basically, yes, as Marilyn was saying, this is done, these DCEs are done through the Health and Human Services Department of the US government, which is headed by Xavier Becerra, and that is a political appointee. So our Congress people can't do anything specifically directly. However, one of the champions of defeating the DCEs, Washington State's Pramila Jayapal, Representative Pramila Jayapal, has worked with PNHP and composed a letter that was sent to Xavier Becerra asking them to halt expansion of DCEs and for Congress to oversee the sunsetting of these programs. Claire was fantastic in working on that as well, because it's activists like us who help, get the word out on this and help people get in contact with their representatives in order to voice your opinion, because we still have a representative democracy, despite what a lot of other people are trying to do about that. So you can certainly still, even though that letter has been sent, you can still write to your own congressperson. And Rana, I'm not sure if, maybe we can provide links, things like that that can be, in the YouTube or however it's done for viewers to see. But there's letter templates, if you don't know what to write, but you can certainly just be in touch with your representatives to tell them that you do not want for this to happen, that you want that 98 cents to go to your health, not just 60 cents. You should also inform everyone who is on Medicare that this is happening. So if, like me, if I myself am not on Medicare, I know you three. And if you three didn't know, I would tell you. I would tell my grandparents. I would tell my older coworkers. I would scream it from the rooftops. Just let them know that this is happening, and it's happening without your permission, without your consent or knowledge, and that you at least want to learn about it and make an informed decision, because this is America and we're supposed to have freedom, right? Well, that's not freedom. Another thing is to encourage those people who are on Medicare to see if they have been placed into a DCE already. And let them know, right? They have the option to opt out.
No, they don't have the option to opt out. And that's part of the problem. So the only way they can opt out is to change their primary care doctor. And if you really love your primary care doctor and have a good relationship, then that's the only way you can opt out, by changing your primary care doctor.
Yeah.
Well, I'm guessing that some of the primary care doctors who are now part of bigger practices, it isn't actually the individual physician who makes the call. It's their umbrella agency that hired them.
Yes.
Exactly.
Yes.
Right. And so now that there are so many doctors' offices that are under these conglomerate corporate health systems, like NYU Langone in New York and in parts of Florida, here in Connecticut, Yale New Haven Health. It's not a private practice anymore. It's owned and operated by this huge healthcare system that their objective is to make money. And if you die in the process, what do they care? You're just a social security number, right? Yeah. And just as Rhonda was saying about the HMO Act, how does that align with the Hippocratic Oath? You know, it's like we're in the Matrix and we're just money batteries for the big, for the big squiddy things, So yeah, do look into yourself if you are in a DCE managed program. And there are other petitions that are around. There's a PNHP petition that you can sign. There's a Public Citizen. They're another great organization that they have a petition. You can also contact Liz Fowler to express your revulsion at DCEs.
Yeah, so for those of you, so nowadays I understand from people who know that writing letters to Congress people isn't that effective. You can send a postcard, or you can contact. A lot of Congress people nowadays have call. And if you want to call, the easiest way to do it is to call 202-224-3121. When you call, that's a switchboard at the Capitol. You give your name and your zip code, and they will give you who your Congress people are. Right. You don't even have to know who you're calling. You just say, my name is so-and-so. I live in blah, 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 zip code. I want to leave a message for my congressperson, and they will direct you. That's 202-224-3121. And we're asking everybody, call your congress people, because we want them to barrage. We're starting to have some effect, because Becerra is now wanting to go before these committees, and Liz Fowler now wants to meet with Jayapal. So we're starting to have some effect. So, but everybody call that number, and we should flood the lines, phone lines, but that you don't want the DCEs.
And we have scripts for that too. Again, if people are nervous to speak, and you'd be leaving a voice message. You wouldn't be speaking to your representative directly, or maybe you would speak with their staff, somebody who answers the phones, but you would still deliver that scripted message if you so chose.
And we'll put a little slide at the end of this interview when we
Yeah.
post it with the phone number and with like the website. PNHP has a huge amount of information, including a couple of slideshows that really give in detail information about what DCEs are and how they threaten healthcare.
Another thing is, and this is what we have been working on at Medicare for All Connecticut, is to also investigate if your state has any similar schemes in place or in the works that would do capitation of payments, capitation payment plans to state Medicare, state Medicaid, similar to how the DCE payments are structured. And in Connecticut, as of right now, there is a plan in place in the Office of Health Strategy for capitation payments in their roadmap strategy, which will basically affect Medicaid patients who are disproportionately low income, Black and brown people, and the very ill who need to continually see service. And similar to DCEs, what this is doing is, again, paying doctors, paying medical providers a single set rate to see a patient if they see that patient once or if they see that patient 10 times. And that will disincentivize medical professionals from seeing those patients who need more care, because if you come in 10 times, they're getting paid, a tenth of what they would be paid under a traditional service, which is a fee for service structure. And so we need to also stop that because this is making barriers to care and really becoming a struggle for people who rely on state services to help them just function and be part of society. So do also check your own state's shenanigans, if there are any, and make sure this isn't happening on the local level as well. And finally, look up programs like ours, organizations like ours, like PNHP, Medicare for All Connecticut, because we are average everyday citizens. You guys are physicians, so you're much more brilliant than I am, but average everyday citizens who are fighting, to ensure that your tax money that you have worked for and paid for your entire life goes towards that 98 cents and not towards Wall Street's 60-40 split, because they certainly don't need any more of our money, but I need all of my care. So look us all up, join in whatever capacity you can, donate, and yeah, the most important thing is to make your voice heard.
And I just wanted to add that in Connecticut, there is currently they're collecting public comments related to this primary care roadmap. And I have to tell you, I worked for Head Start during the Clinton years, and we had Medicaid Husky expansion in Connecticut at that time. And I remember talking to the pediatric dentists who would volunteer their time to do dental cleanings and screenings for our Head Start students. And they frankly did not want to participate in the Medicaid expansion for that reason, that it was not fee for service. And they thought if they accepted as a young child just to do a cleaning, if they had severe dental problems, it would be a loss for them. And the contracts were written that made the doctors assume quite a bit of risk. I don't know if it had the sort of incentive that the DCEs have to encourage doctors to cherry pick and upcode and make a lot of money in the process. But the stick part of it, the restrictions were already there. So that's been a concept that's been around for quite a while. Yeah, for more information, I do recommend that people go to the PNHP website, and we'll put a slide in for it in the Medicare for All Connecticut website. If people want to send a letter for Connecticut, Sivan, where should they find out about it?
It should be on our website, which is Medicare for All, the number 4 all ct.org. I think we have an action section, and under there you can see, and it's a letter template, again, that gets, you just put in your information and it sends it off to the Office of Health Strategy. But as always, if you have your own personal story, that's always more the most effective way. And you are the only one who knows your story. So you should definitely include that in there if you are a Medicaid patient yourself, if you know anybody, if you're a physician who sees Medicaid patients, including your own story in there will really pack the most punch. But another thing I just wanted to say about DCEs and any type of privatization of healthcare, I think the most important question to ask, and whether it be to a lawmaker who is fighting for DCEs and possibly in the pocket of insurance industry, lobbying, or the insurance companies themselves, I think the most important question to ask is how are private equity and insurance companies who are investing in DCEs expecting to achieve a return on their investment? So how does anybody receive a return on their investment in a traditional sense? It's by reducing costs as much as possible and maximizing profits. And how do you do that in healthcare? But by reducing costs, meaning you reduce access to services. So if somebody does have hypertension and needs that medicine, they're going to deny that, but keep that money that they've taken from the tax system, okay? And you are out on your butt and they are out on High Street. So if they have any better explanation to that question than what is the obvious answer, I would be thrilled to hear that. But when you're playing with people's lives here, that's really the question they need to answer.
Well, thank you all. Our hour is kind of up. I just want to make one other small point that this is not just a healthcare issue. It filters down to every aspect of our life. There is no other country in the world where medical debt can lead to bankruptcy, to homelessness, to people staying in bad marriages just so they can keep their insurance. So people staying in bad jobs so they can keep their insurance. There are so many other stressors in life that are exacerbated because we don't really have a healthcare system that works beyond the obvious health outcomes. So thank you so much for joining us. To everyone who's watching, take action, go to the websites, write letters, make phone calls, send postcards, tell your friends, tell your family. This is really important. And thank you, Claire, Sivan, and Marilyn for joining me today. And I'm not sure what we're doing next week, but we'll be back, and have a good week. Thanks.
You.
Thank you.